It is my pleasure now to introduce Dr. Cait O'Sullivan. I have so many funny memories of road trips with Cait and Tom, where Cait and I look at each other laughing hysterically as Tom devises a new treatment for my psoriasis, or he's telling stories while we are mountain biking. Again, also happy to spend as much time with Cait and on road trips with the TI faculty as possible. Cait O'Sullivan has a clinical pharmacy background in acute general medicine, long-term care and community practice. She received a Bachelor of Arts from the University of New Brunswick with an honors in medical anthropology and a Bachelor of Science degree from Dalhousie, and did her doctor of pharmacy degree at UW. Cait has a research interest in the drug approval process and clinical practice guideline methodology. And without further ado, I'll pass it over to you, Cait.
Thanks, Aaron. Okay, can you see my slides okay?
Yes.
Okay, thank you. I'm gonna get rid of this if I can. Okay, so I'm really nervous about this talk. We'll explain in a minute, but I hope to talk to you a little bit about why having someone on the team look for more information is important. I work strictly as a drug evidence pharmacist. I don't practice clinically anymore, so sort of those useful wrap-ups at the end from our clinician speakers I won't be able to provide. So I'm hoping that clinician and patient voices will be added in the comment box, because I think those are really important and ones that I can't satisfy anymore. Why Bupropion? Well, our team uses drug approval packages to learn as much as possible about drugs, to bring information to clinicians to help them make really informed decisions. We know that this information really shapes the evidence that is available to us. And we learned this year that the drug approval package for Bupropion, or the brand name Wellbutrin, is publicly accessible. And this is unusual because it was first approved in the 1980s, and really these packages are only available for drugs that have been approved from 1997 onwards. The package is 683 pages in length, and just see there's something in the chat box. I won't be able to follow the chat box, so just text me if there's anything I should know. You're saying there's an echo. Is that, is it still echoing?
Yes, Dr. O'Sullivan. Do you have headphones that you could use?
I do not.
Okay.
Is the echo really bad?
It's not too bad,
Okay.
but there is an echo, just so you are aware.
Okay, sorry about that. I might be able to open a door then. Yeah, sorry, that's the best I can do. I'm at the hospital, so yes, so almost 700 pages of reading. I always offer to send it to people and they never take me up on that. But in a word, the approval for Bupropion was turbulent. I thought I would walk you through some of the information from the FDA approval process, provide a little bit of information that we learned from the Department of Justice in 2012, and also from a systematic review in 2018 that included both published and unpublished data. But I thought I would focus this on sort of a very common scenario we see, and this was a clinical consult that Tom forwarded me. It says, we will switch her from Bupropion SR 100 milligrams twice a day to the XL version 300 milligrams once a day. This is the newer, superior version, and it will also involve a dose increase. She declined to increase her escitalopram, so she's on 2 antidepressants, as it gave her sexual side effects. And the importance of sexual dysfunction as an adverse event associated with antidepressants is increasingly being recognized. And you'll see in the slides on the website, I've included more information on that. So I thought I would answer, is the extended release version superior? What is known about combining these drugs? And should we consider the potential for Bupropion in triggering a prescribing cascade? So I'm a little bit nervous because I just learned that Eric Turner has joined us, and he really should be the one giving this talk, because it's through Dr. Turner's work that we've learned so much about the evidence for antidepressants. So he looked through with a team for 12 antidepressants, 74 trials were included in these drug packages, and about a third of them ended up not being published. And the consequence is that if we just relied on the published literature, we would have an inflated sense of how efficacious these medications are. So it's really important, of course, that we look for systematic reviews and clinical practice guidelines that do the work of looking for unpublished literature. So this was my understanding of bupropion, and I thought I would share this with you and see if this reflects your understanding also. So this was an article published in 2005, and it was intended for a primary care audience. And it kind of compares the three formulations of bupropion: the immediate release, the sustained release, and the extended release version. And it demonstrates what the concentration curves look like at steady state. So for bupropion IR, the immediate release, it's given 3 times a day. There's 3 bumps in the concentration curve. For the SR, given twice a day, there's 2 bumps. And for the XL, the newer version, there's just 1 bump. And the article tells us that this decrease in the number of peak plasma levels with the XL formulation may result in better tolerability, and that they were indicating that there's they used the word compliance, a compliance issue with the sustained release formulation because it needs to be given twice a day. We're most interested in Canada in these comparisons because we don't have the immediate release formulation in Canada. I now know that this was a marketing article, and I know this because I looked to see who the corresponding author was, and he works for a market research and consulting firm focusing on emerging technologies. And the emerging technology was the extended XL formulation, extended release. And what they were facing sort of throughout this period of time was increasing market competition from SSRIs that you'll know are dosed once a day, and also generic versions of bupropion for the SR formulation were becoming available. And so also in the abstract, without any evidence provided in the article, they promote off-label uses. Bupropion, they say, has also been used as an adjunct treatment to reverse antidepressant-induced sexual dysfunction and to augment the effect of other antidepressants. So in looking through the FDA reviews, they do note that there are indeed differences in the shapes of the curves for these various formulations, but you know that the right answer is that the clinical relevance of these differences cannot be predicted. So I've been persuaded by marketing like this before for other medications. I've told patients that this newer formulation or this new drug is better because there were fewer peaks. And I wonder if you've ever been persuaded. So I was hoping, and I think there's an opportunity now for you to enter your examples in Slido. And I know many of my colleagues here are participating, so they can enter some examples. And we'll chat about them at the end, and then also share with you my specific example. So before I can get into the drug approval process, I just have to tell you in brief how the FDA and Health Canada sort of follows their lead, how a drug even gets marketed as an antidepressant. And it's not based on theoretical mechanisms of action or pharmacology. They do have to compare the new drug to placebo in a 6 to 8 week trial. And the measure of efficacy is usually looking at a depression symptom severity scale, such as the Hamilton 17-item scale, which I've sketched out here. And it covers a lot of domains, and it's scored out of 52. And so the trials, to be considered positive, according to the FDA, need to show that there's a statistically significant difference between the drug and placebo at the 6 to 8 week endpoint. So the FDA will call a trial positive if it's achieved statistical superiority. And there's absolutely no judgment on clinical relevance. And the FDA may also depart from requiring 2 positive trials. We're actually hoping Dr. Turner will talk to us at some point about one of these very current examples. So there are also ways to get a drug approved if it's a new dosage form without submitting efficacy trials. So for bupropion sustained release and extended release, they went through an abbreviated approval pathway, which means efficacy trials may not be required. And that was the case for these two formulations when they were approved. They just have to show that the newer formulations were similar to the immediate release formulation according to these parameters. So maximum concentration, area under the curve, and minimum concentration. So while we don't have the immediate release formulation in Canada, I kind of need to go back to that, given that the efficacy of the ones we do use was established based on the immediate release formulation. So looking through this massive 600-page, almost 700-page package, you'll have to believe me that I've really truncated this here, but the drug company submitted 5 pivotal efficacy trials to the FDA, and the FDA reviewed them and considered, so remember this just means statistically different from placebo, the FDA judged that 2 of them were positive and that 3 of the trials were negative or inconclusive. So the drug was actually approved towards the end of 1985. They began marketing it for a couple of weeks, and then they took it off the market. So it was a little bit turbulent, and there were more negotiations into 1989. At that time, in end of 1985, the FDA did ask for additional post-marketing commitments. They wanted the company to demonstrate that the drug works in an outpatient population for a trial that lasts longer than 3 weeks. And they also wanted a better characterization of what had been identified as a dose-related seizure risk associated with this medication. And so specifically in the FDA review, it says the sponsor's submission failed to establish that the drug was effective for more than 3 weeks in inpatients. So these 2 trials enrolled inpatients only, and they only followed them for 3 weeks. So that was the body of evidence when the drug was first approved. And of course, they wanted demonstration that the drug worked in the outpatient situation, because that's when the drug would be used most frequently. So they achieved some of these post-marketing commitments by 1989. Sorry, I have another chat, which is, okay, sorry, that's not relevant to this. So they did achieve some of these post-marketing commitments in 1989. They submitted the positive outpatient trial that the FDA wanted, and they also completed the follow-up safety study to better estimate the risk of seizures, which was 0.4% when the drug was used in doses up to 450 milligrams per day. So by this point, we have this body of evidence, 6 efficacy trials enrolling about almost 800 people, 3 that were considered positive and 3 that were considered negative. And sort of the main debate between the FDA and the drug company in 1989, when they wanted to relaunch the drug, was how do we best communicate this risk of seizures? And the FDA wanted the drug to be labeled as a second-line drug, but there was a lot of negotiation back and forth, and that takes up a lot of this drug approval package. And the FDA acknowledges that they backed off on that requirement as in terms of labeling bupropion as a second-line antidepressant. Subsequently, there was another post-marketing safety trial that offers a bit more reassurance on the safety risk. It limited the titration of the drug to 300 milligrams per day, which is our maximum dose in Canada. Although we see in BC, many patients are on excess of this dose, and that's when the incidence was lower because they had known all along the risk of seizures was dose-related. So is the extended release formulation superior? Of course, that's not been demonstrated. And, you know, many pharmacists will tell me that it doesn't really matter now anyway, because they're both available generically and there aren't large cost implications to this. But I guess what irritates me a little bit is language like superior. It implies to the patient that the primary care provider had initially chosen an inferior medication. And I think it contributes to questions of trust. But it also implies we know that her outcome will be improved if we switch her from the SR to the XL version. And of course, that's not been demonstrated. I threw something else in here. What's known about dose response? I wasn't going to talk about this, but it's something that we've been looking at a little bit. And so the current US prescribing information for bupropion says we should target 300 milligrams per day. So that implies to me we know that increasing the dose up to 300 milligrams per day, as was suggested in this clinical consult, improves outcomes. And I was conflicted by this because when I had read the FDA review in 2003 of the XL version, they acknowledged that a dose-response relationship for bupropion has not been well characterized. So how do you define a target dose if that's the case? So it turns out, I categorized here. So remember I mentioned for the immediate release, there were 3 positive trials, 3 negative trials, and then I pulled out which ones were the outpatient trials, given the important relevance of that patient population. And one was negative, one was positive. And the 300 milligrams comes from the fact that that was the dose used in the one positive outpatient trial. This doesn't really tell us much about dose response. So this is where I learned from Dr. Turner's work that although the sustained release and the extended release formulations were approved based on having had the efficacy established previously with the immediate release formulation, there had been an attempt in 1994 to submit pivotal efficacy trials for the sustained release formulation. And this amassed to almost a doubling in the body of evidence than we even had submitted initially for the immediate release. But the FDA judged that, in looking at these 3 trials, there was no consistent or coherent evidence of efficacy that emerged from this wealth of data. But what these trials do allow us to explore, and you'll find this in your handout so you can look at them more closely, is dose response. So this is from the 3 trials, the 3 outpatient trials that were 8 weeks in length. This is baseline scores using the Hamilton Depression score out of 52. This is how much people improved in the placebo group and improved with the drug at each dose. And this is the difference for each dose compared to placebo out of 52 on the Hamilton Depression Rating Scale. And you can see here, if you look closely, there really isn't a pattern of an improving response when you increase the dose, particularly in this trial that went from 100 milligrams per day up to 400 milligrams per day. So the FDA concluded also from looking at these trials that there was no evidence of a dose-response relationship. And so consistent with, what I've been showing you, that 30% of trials end up being unpublished, that was the case with these 3 bupropion trials. Only one of them was published, and it's just so ironic. It was published in 1998 before they had conceived that they were going to market a version as a once-a-day formulation. And in looking at the people who received 150 milligrams once a day versus giving it twice a day to equal 300 milligrams per day, there wasn't a difference in the effect, right? So they're actually emphasizing the convenience of bupropion SR as a once daily drug. Because bupropion SR 150 may be administered either once or twice daily with at least equal effectiveness, patients might benefit from the convenience of this. So I thought this quite ironic because, a few years later, they're trying to indicate that the SR version needs to be pushed to 300 milligrams a day. So of course, this clinical issue isn't really a clinical issue unless you're increasing someone to 300 milligrams per day. So this looks like a lot of work to learn anything about dose response. So I wanted to show you something practical. We often find, if we just search the Health Canada drug product database, and we pull up the full monograph for a drug, you can, and I usually you don't have to fill in all of these boxes. I just put in the brand name, and you can just search the PDF by dose or response. And there's usually information in here about dose response that we don't find anywhere else. You don't find it in the eCPS, you don't find it in LexiComp. And of course, we were so amazed to see that in the Health Canada bupropion sustained release monograph, that effect does not improve with increasing dose, indicating a flat dose response relationship. And they actually indicate that the usual dose for bupropion is not 300 milligrams per day. That's the maximum. It's 100 or 150 SR once a day. So we also have had the benefit of this massive systematic review that was published in 2018. I'm going to skip ahead to 2018 and come back to 2012, where they worked for more than 6 years to amass as much as they could in terms of the published and unpublished trials for antidepressants. And look at this body of evidence, over 500 trials, almost 120,000 participants. And they did this by searching international trial registries, regulatory agencies, and drug company websites. And so we need to look at this because, of course, more trials occurred than just what were in the FDA approval packages for bupropion. 33 trials, again, about a third of them unpublished, mainly smaller and older trials with higher unclear risk of bias for missing outcome data. And their main interest was looking at the comparisons between drugs. And for bupropion, compared to the other antidepressants we commonly use in BC, bupropion was neither more efficacious, it was neither less efficacious than any other antidepressant in BC, but their certainty in the comparisons for this drug was low to very low, in part because of the small trial sizes and the fewer comparisons to other drugs. But we were mainly interested, because I've shown you that there were these negative trials, we were mainly interested in how does this drug compare to placebo? And so there's been some debates in terms of how this data was represented statistically, which is beyond the scope of this talk. But what they did report and were as an efficacy outcome is the odds ratio, the odds of achieving at least a 50% improvement in the depression severity score in these, what are albeit short-term trials, 4 to 12 weeks. And so by the information they provide, we can estimate that approximately 10% more people achieve this response if you agree that this is a clinically important response compared to placebo. So approximately 10% more responders using that definition. The picture is still incomplete for me in terms of sorting out which drugs, should we prioritize in our formularies, because there isn't a full accounting yet of the adverse events from the unpublished trials for bupropion as well as other antidepressants. But that team is working on that, thank goodness. So they have a protocol in the works for collecting adverse events for the 21 most commonly used antidepressants, and also looking at the longer term trials, but we need to acknowledge that piece is missing. So what is known about combining bupropion with other antidepressants? And this is where we see it used most commonly, I think. So I was thinking of the two questions. Is there an additive antidepressant effect, and does it treat sexual dysfunction like the drug company was claiming in 2005? So
Kait,
there's a
may I interrupt for a second? You have about 5 minutes left.
Okay, great. So there's a massive Cochrane systematic review that searched for unpublished trials, and it was looking at compared to continuing the first antidepressant unchanged, if we switch or add a drug in someone that we've defined or categorized as a non or partial responder to the first antidepressant, which drugs actually have evidence. And they found a small body of evidence overall, and actually no eligible trials for bupropion. So no eligible trials for bupropion being added on to another antidepressant for an additive antidepressant effect. In terms of the treatment for sexual dysfunction, this is quite interesting because we often think that Cochrane reviews are very nihilistic. This one was actually very, positive, I would say, about bupropion as a treatment for sexual dysfunction caused by antidepressants. They did not include a search for unpublished trials, and I haven't found a systematic review that answers this question that does that. And they say for women with antidepressant-induced sexual dysfunction, bupropion at higher doses appears the most promising. They found 5 trials, almost 600 people, and 2 of these trials statistically favored bupropion. And they were able to meta-analyze 3 of them because they gave the data in a way that they could combine. And it's unfortunate that the Cochrane Review hasn't really noticed that this trial, which contributes the most amount of data, has been retracted. And in fact, this author, who is the same author for the second trial, has had many trials retracted. So we're really left with this small trial, 42 participants. I don't need to tell you that there are methodologic limitations beyond just the size of this trial for you to see that it really doesn't amount to a convincing body of evidence. Yet this trial wields a lot of influence still. And if there's time at the end, just because it's just so remarkable, it influences the recommendation in UpToDate that favors bupropion as a treatment for sexual dysfunction. I did do a search of the GlaxoSmithKline clinical trial registry, and I didn't find any additional trials looking at it as a treatment for sexual dysfunction. But it was amazing to me, and I hadn't done this before, how many other trials I found, like Bupropion XL for depression in the elderly, no statistical difference, not published. Bupropion with depression not responding to SSRIs, no statistical difference, not published. So what I really learned mainly about this topic is we need systematic reviews and clinical practice guidelines that do this amount of digging. It's a lot of work. So of course there's insufficient evidence to inform if there are clinically relevant benefits and harms in combining bupropion with an SSRI. So why do we do it so much, and why was that my narrative? I used to say to patients, oh yeah, that's the best place for bupropion. Well, the Department of Justice in 2012 provides some insight into this. GlaxoSmithKline, so the company that currently markets the drug, pled guilty to several fraud allegations involving several drugs, including bupropion SR. So from 1999 to 2003, they engaged in a nationwide scheme to promote Wellbutrin sustained release as safe and effective for indications, doses, and populations that the FDA never approved as safe and effective. And you'll see many of those indications if you look at the notes later. Reports from physicians, they included, what was the main message you gleaned from your visit with the sales rep? And it was a useful medication in conjunction with SSRIs to deal with sexual dysfunction. Very good as an add-on medication to other SSRIs. I think it's the marketing rather than the science that contributes to how we use this medication in BC. And I noticed also in this 2012 report that this author alone received $1 million from GlaxoSmithKline in 1 year alone to promote it for off-label use. This last thing I'm just going to raise, should we consider the potential for bupropion to trigger a prescribing cascade? This hasn't been looked at systematically. I would like the research skills to do this. I don't. But when I was researching this, I just noted various cases published on this. And it just made me realize I knew very little about the drug when I was counseling patients on it. So from the FDA review in the 1980s, it describes the pharmacology, the way the FDA understood it, that it had several similarities to amphetamine, that many patients with bupropion, especially at the beginning of treatment, experienced restlessness, agitation, anxiety, and insomnia that required treatment with a sedative hypnotic. And even in the Health Canada monograph, it identifies insomnia and anxiety as dose related. That's the other reason we use the Health Canada full monographs, because we can learn, which adverse events might be increased as we pursue, doses that actually haven't been shown to improve our main objectives. And they also talk about concurrent treatment with sedative hypnotic drugs. I think this would make for a useful research project, since we're so often adding on bupropion to, say, an SSRI. Do we then see medication lists that also include sedative hypnotics like zopiclone, which we also use very commonly? I find it really hard to give presentations when a question that clinicians really want answered, like what should I do next if the first antidepressant hasn't been shown to be very helpful for a patient. To say that there's a small body of evidence overall is not what anybody wants to hear. But I do think it's more dangerous if I gave you a beautiful algorithm that inferred that it had been answered. And it was just kind of interesting. I'm going to leave you with this question at the end, but there was a review of 21 clinical practice guidelines. So no shortage of clinical practice guidelines, more guidelines than there are trials, looking at next steps after an inadequate response to a first antidepressant. And they really noted important guideline deficiencies, like they failed to engage primary care clinicians and patient voices, deficiencies in the rigor of the development and editorial independence. And this also, really a significant variability in the recommendations because of the limited evidence. They recommend that this uncertainty needs to be better highlighted in clinical practice guidelines, but not everybody agrees with that. So I wanted to raise this. It's a discussion that's been going on for decades, but it's recently been highlighted now, I think, in the context of COVID-19. How should clinical practice guidelines address uncertainty? So this is your chance to vote, because I see these as two sort of contrasting viewpoints. This was in JAMA recently, a solution for guideline overkill, more guidelines or shared understanding. And they recommend that guidelines should look like half-drawn maps, indicating where the good roads are, but equally important, showing where there are no good roads. Does that resonate with you, or do you lean more towards this? This is the position from the GRADE guideline group, who are very fundamental in providing structure for how guidelines are produced. They say developers of guidelines should make recommendations when evidence is sparse or doubtful, as they are best equipped to do so, and evidence shows that health professionals want them to. So if you go to Slido, I want to see what your thoughts are. Wow, okay. So it's changing. There's more people voting for A, but more people kind of increasing in the B. So we've got 85% for A and about 15% for B. So I'm gonna end there. I wanted to, Erin, can we look now and see if people provided examples of drugs where they've been persuaded about differences in peaks?
Yes, Cait. First, I wanted to say thank you for an incredibly insightful presentation. You had no reason to be nervous. It was fantastic. I'll read out some of the examples. Lantus versus NPH. NPH versus Glargine versus Detamir versus
also basal insulins, okay.
Yeah. IR versus CR opioids. Long-acting injectable antipsychotics. Oxybutynin, another one for Lantus.
Yeah.
Those are the examples that were provided. So yes, a fantastic question, and people definitely resonate with the sentiment. So if I could ask you.
Oh yeah, do I have a second just to show? Because someone asked me about UpToDate. Can I quickly show it, Erin?
Of course.
Okay, so this was my example, OxyContin, of course. I used to draw this picture out for people, showing how OxyContin would keep them 100% in pain relief because it had fewer peaks and fewer troughs. It turns out that was fabricated. Oh yeah, so UpToDate, this was interesting. So they say for females, it's written by these fellows, for females with SSRI-induced low libido, we suggest augmentation with bupropion at relatively high doses. It's on the basis of that one small trial. And this was the funny part. Improvement of desire and frequency was greater with add-on bupropion. However, irritability occurred nearly 3 times as often with bupropion than placebo, 60 versus 23% of patients. I hope you're laughing at that. I was like, what? Who's going to follow that recommendation? Anyway, it was based on this very tortured small trial that GlaxoSmithKline used to promote the off-label use of bupropion. They even called it an antidote. So that was the basis of that. That's all I know. Erin?
Fantastic, Cait. We're a little bit over time, but there's One comment that I think is great: how can we ensure that all prescribing professional training programs include this lecture to illustrate the evidence and approval history for common medications? It's urgently needed. And I would agree. And then one comment or question that I believe is from a friend of ours. Have you given active feedback to UpToDate? Like it or not, it's extensively used. I have found editors at UpToDate reasonably responsive to my numerous tough questions. It's being used at high cost. Why can't we challenge the authors?
Great idea. I submitted feedback to the Cochrane review since they didn't know the major trial had been retracted. UpToDate was actually how I twigged that big trial had been retracted. So that was kind of cool, but then the rest of it fell apart. So I'll do that. That's a really great point.
Okay. And then one last question. Bupropion is the only amphetamine-derived antidepressant on the market. I only found this out recently, but realized that this might explain why it is marketed as an alternative to many other classes of antidepressants. It may also explain why it's tolerated despite its low efficacy. Do you have any comments?
No, that's, yeah, it is different pharmacologically from other antidepressants for sure. Yeah, no argument.
And then one final comment: no wonder people mistrust medicine. We are collateral damage. And so on that happy note, I think I'll thank you again for a wonderful presentation, and I'm sure you can enjoy a well-deserved break now.
Thank you for tolerating it.